First, let me introduce you the panelists. We will be doing a great disservice if I would read through the extensive bios, because our panel is extremely good and their accomplishments are very long. So we will stay here until probably 4 o'clock. But let me give you at least an aperçu of what our panelists are. Let's start by Tom Boyki. He's a senior fellow for global health, economics and development at the Council of Foreign Relations. He's also an adjunct professor of law at Georgetown University and a consultant to the Bill and Melinda Gates Foundation. He was also a Fulbright Scholar in South Africa, and he works as a staff attorney at the AIDS Law Project. He's a member of the advisory committee of the Clinton Global Initiative and has served as a temporary legal advisor to the World Health Organization. In 2013, the World Economic Forum named Mr. Boyki one of its global leaders under 40. Then, next to him, we have Dr. Alejandro Yepes, the CEO of IDC Latin Americas in Medellin, focused on cancer. He's also a specialist in public health in San Tomás University in Bogotá and epidemiology at the Universidad de Antioquia. He worked in Antioquia's government as a director of public health and secretary of health to the state. And now he's back to the private sector. So in our keynote speaker this morning, he's one of the people that are going back and forth. Next, we have Dr. Bolorma Tumendemberel. I hope that I have done justice. She's the Vice CEO and Chief Commercial Officer of the United Family Intermed Hospital in Mongolia, jointly managed by United Family Healthcare. She pioneered this hospital project since 2005 until its completion, and has become the first hospital built in Mongolia according to the European standards, aiming to introduce high-quality international healthcare services across the country. Yet again, she was in the same public-private dance. She serves at the Ministry of Health as Director of International Cooperation Department and as Department Health of the National Health Agency. Last but not least, we have Dr. Brian Pereira, the President and CEO of Istera. He serves as President and CEO of the Physician Associations at Tufts Medical Center from 2001 to 2005. He was the chairman of the board of the Harvard-MIT, my alma mater, so congratulations to you, sir. Biomedical Enterprise Program, president of the National Kidney Foundation. He has contributed over 200 scientific articles and has edited the leading textbook, Chronic Kidney Disease, Dialysis, and Transplantation. So welcome to you all. I think probably it's interesting to set a little bit the scene before our speakers give their particular views and their areas of expertise. Today we're going to talk about non-chronic disease. And if one looks broadly, there has been kind of 3 areas or 3 time periods. The first one, the time from 1900s to 1950s, where we were in infectious diseases. And given to the improvement in sanitation, hygiene, animal control, and the introduction of penicillin, we had a dramatic fall in communicable disease. Then the 1950s to 2000s, acute hospital care. Combined with a decline in communicable disease, we basically had an increase in deaths from chronic disease. People are living longer. And 2000 to the 2050s, technological advances and increased pharmacology are enabling people to live longer. So this is, I think, what the developed countries are going to be facing more and more as we move. To give you an example by graphs, if one can look on the left-hand side, this is the mortality rates for infectious disease in the States. So you see the introduction here, better sanitary standards, and penicillin led to a dramatic decrease in communicable disease. And now what is the main source of death is cancer and heart disease in the States. But one has to also figure out, well, what does it look like in emerging markets? These are the mortality rates by income and the cause of disease. So in green, we have communicable diseases, and in red, we have non-communicable diseases. What is interesting to note, high-income and upper-middle-income countries, you see the red bubble is much bigger than the green bubble. The leading cause of mortality is non-communicable disease. In emerging markets, particularly lower middle income and low income, a communicable disease is still strong. In low-income countries, they're dealing with the duality of disease. They still have very strong communicable disease, and non-communicable disease is increasing at an alarming pace. Just to give you one example, in low-income countries, the share of chronic disease increased from 29.5 to 40.2 in a decade. So where are those diseases located geographically? Well, again, there's a disparity between what are the leading causes of death. East Asia and the Pacific, South Asia, and high-income countries, you see the red bubble, which is a non-communicable disease, is very high. If you look at Africa, for example, the blue bubble, which is communicable disease, is still very high. But as Tom is going to cover, the rate of increase in non-communicable disease in Africa is definitely frightening and has to be the focus. Mortality projections. Life expectancy over time. How are different regions faring today? So this is the high-income curve. So MENA today is where high-income were in the mid-1970s. LAC today is where high-income were in the 1990s. What is interesting is that Africa doesn't even come on the scale of high-income countries. So we have to compare it to the middle-income countries. And Africa today, 2012, is where middle-income countries were in 1970, which is a frightening statistic. So looking forward, the projected expectancy rate by region, none of the emerging market regions are expected to catch up with the developed world. Some of them are doing better, so East Asia, MENA, and ECA will follow LAC within the next 15 years. But then look at South Asia and look at also Africa. Africa, around 2050, is expected to be where South Asia basically is, which is, again, frightening. Non-communicable diseases, and I think Tom will touch that very much in detail, no longer a rich country a problem. Higher income and urbanization often result in unhealthy lifestyles. That is correct. But we're also going to see this morning that prevention and also the delivery of care is what is increasing dramatically the mortality rates in emerging markets. Chronic diseases are taking over. Yes, they are. And this is where the focus should be. 63% of deaths in emerging markets are linked to chronic diseases. Some progress, but more focus and resources is needed. Great progress has been made in infectious diseases. People live longer. Yes, but still the healthcare system are designed for acute problems in big parts of the world, and the resources are not shifting in line with the disease, particularly in regions like Africa. And the last slide, in here, mortality rates by income and causes of disease. Where is basically non-communicable diseases bigger? In low and lower middle income countries. Is not a rich country's problem anymore. Which are the two regions where we see the most challenges is South Asia and Sub-Saharan Africa. And if you see the rates of increase between now and 2030, they are very, very important. So going forward, Tom is going to give you a high picture, a view of EM disease, prevention, and also country-led actions. It's going to be followed by Alejandro, which is going to give you a picture of cancer treatment in Colombia, followed by Brian, which is going to talk about kidney and dialysis globally and also in emerging markets. And last but not least, Bolorma is going to talk about non-communicable diseases, prevention, the role of the private sector with her experience in Mongolia. So without further addition, please, Tom.
Well, let me start by, I'm just waiting for my slides to come up, but let me start by thanking the IFC for this invitation to speak and a kind introduction by Jean-Pierre. It's a treat to be here and be asked to speak to you about this topic. What I was asked to discuss was to provide a bit more detail on the impact non-communicable diseases, heart disease, cancers, diabetes, chronic respiratory illnesses, and others are having in low and middle income countries, and to set up the discussion on what that means for how we engage on these problems and the role of the private sector. In doing so, fortunately, I will not be just relying on my own views. I recently led a task force at the Council on Foreign Relations that looked at this problem. For those of you that don't know, the Council on Foreign Relations is a membership organization, a think tank. It was started after World War I. Its task force program is one of the signature things, the council initiatives that the council has. They're typically led by former U.S. presidents or former secretaries of state. We've had 73 task forces. They look at pressing, urgent problems of foreign affairs. This is our first devoted to global health, a global health challenge, which gives you a sense of the seriousness with which we look at this issue, but also a sense of the size of the problem. Now, like all our task forces, this had a good group, and really by task force standards, actually, it was pretty spectacular. The co-chairs of this task force were Tom Donilon, who is the National Security Advisor for President Obama during his first term, and Mitch Daniels, who is the current president of Purdue University, former governor of Indiana, former head of the Office of Management and Budget. But we also had two former U.S. National Security Advisors on this task force, three heads of our Ministry of Health, or Department of Health and Human Services, head of USAID, head of U.S. Department of Agriculture, two former senior U.S. trade officials, really you name it, current vice chair of Barclays Bank, many others, and it's a really spectacular group. And the way that we had gotten a group like this involved in global health, let alone non-communicable diseases, which none of them really had a position on before, is we asked them a series of questions. And we said they could answer these questions if they wanted to in the negative. And the first question we asked them is this a crisis? Are non-communicable diseases presenting a crisis in low and middle income countries? Cancer, diabetes, these have been concerns in high-income countries for a long time. Why should we care that these are increasing in low and middle-income countries now? And to do that, we looked at the data of what this looks like in low and middle-income countries. And in doing so, we primarily relied on the global burden of disease, data from the Institute of Health Metrics and Evaluation. Chris Murray was on this task force, and it relies, most of the data you'll see today is from the 2013 data. We had actually pre-publication, which was very generous of them. And what we found is non-communicable diseases are rising faster, much younger, and with far worse outcomes in low and middle income countries than you see in their wealthier counterparts. What do I mean? To provide some specifics to that, deaths from non-communicable diseases in low and middle income countries have increased 53% since 1990. That is nearly twice the rate of population growth in low and middle income countries over that time period. They're also arising much younger. The World Health Organization, when they think about prematurity, they look at 70 and younger. We decided to take a stricter standard, and we looked at age 59 and younger and what the burden is. And what you find is regionally, 80% or more of that burden in sub-Saharan Africa and South Asia and in some other countries around the world is arising in populations 59 and younger. In 2013 alone, 8 million people perished from non-communicable diseases before the age of 59. Over 90% of those deaths happened in low and middle income countries. They're also having significantly worse outcomes. Diseases that are entirely preventable, like cervical cancer, or entirely treatable, like type 1 diabetes, in many low and middle income countries are effectively death sentences. With people getting sick earlier, dying younger, it has economic effects. What you're looking here is at the disability-adjusted life years and when they arise in low and middle income countries, and what you see is a surge of that in populations 35 to 59. That's, of course, an economically productive period of life. It's people who manage households, and it has, given the scale of this problem, significant economic effects. It resonates, again, through households and affects the financial stability of those. It affects social and welfare expenditures and the labor force on a national level, and that reverberates out globally. You don't have to just take my word for it. According to the World Economic Forum, non-communicable diseases will extract $21.3 trillion in economic costs in low and middle income countries alone by 2030. That is roughly equivalent to the entire economic output of low and middle income countries in a single year. So, should we be concerned about this? That's terrible, but isn't this a sign of some success? Shouldn't we be celebrating that people in these countries aren't dying of malaria anymore? Isn't this a sign of rising incomes spurring unhealthier habits? And to be honest with you, the task force was really surprised by this. When you dig into the data, that is not the whole story, even most of the story in these cases. The rate of increase of non-communicable diseases in low-income countries is 300% faster than the rate of decline of communicable diseases. The rate of increase of non-communicable diseases in lower middle-income countries is a third faster than the rate of decline of communicable diseases. You are seeing some metabolic or behavioral risk factors increasing in low and middle-income countries, but the rates of most of these are still pretty low. If you look at obesity, for example, the rate of adult obesity in a low-income country, 5%. The rate of adult obesity in a lower middle-income country, 7%. In the United States, it's 35%. You see a similar spread on physical inactivity and a lot of the other risk factors that we associate with non-communicable diseases. So what is driving this crisis, then, in low and middle-income countries? And what you find is you do see people living longer, but in low and middle-income countries, that's been primarily driven by improvements in infant and child mortality. You are not seeing those improvements occurring with the same gains in personal wealth or in health systems that you saw in wealthier countries. An example of this, when OECD countries reached a median life expectancy of 59, which happened way back in 1946, the GDP per capita in those countries was $4,300. When low-income countries reached a median life expectancy of 59, which just happened, in 2012, the median GDP per capita was $1,000. So significantly poor. You've seen health spending in low and middle-income countries triple over the last 20 years. That's good news, but it is still relatively low. All of the governments of sub-Saharan Africa collectively spend about as much on health care as the government of Poland. All the governments of low and middle-income countries, representing 5.7 billion people, spend less on health care than the governments of the United Kingdom, Germany, France, and Canada combined, being around 300 million people. Health systems are still primarily geared towards acute care and not towards preventative and chronic care. This has been exacerbated by an increase of certain risks, some of those being primarily driven by unprecedented rates of urbanization. This is particularly true in Africa and Asia, where you're seeing the fastest rates of urbanization occurring, and by some risk factors, particularly tobacco. Tobacco consumption in low and middle-income countries tripled between 1970 and 2000. So, for this reason, I think a lot of people are surprised that the same countries we invest in other areas of global health, and we see as the important countries to invest in the population and prevent or address preventable or treatable diseases, well, if you look at what people are getting sick of and dying of in those same countries, like we did, we looked at the 49 countries where the U.S. government spends $5 million or more annually in global health aid. What you'll find is premature mortality, 59 and younger. The rates of premature mortality from non-communicable diseases are 3 times higher than the rates of premature mortality from HIV in the same countries that we primarily invest in for HIV. What you'll find is that it's nearly twice the rate of HIV, malaria, and TB combined in those same 49 countries, primarily low-income countries. And the problem is getting worse. One of the things we looked at is what is the wealth that a country needs to achieve the health performance you saw just in 1950 in the average high-income country. And what you've seen on child mortality under 5 years, that's declined dramatically over the last 20 years. That's good news. Childhood immunization, better health programs, hand washing, other hygiene practices. But for adults, it's increasing. And that's primarily non-communicable diseases. The good news is this is not a hopeless situation. What you're looking at here is 2 projections. The line on the top is what we project based on standard assumptions of demographic change, population growth, aging, based on the current rates of non-communicable diseases, where you expect low and middle-income countries to be by 2030. The rate on the bottom is where they would be if they had the rate of improvement that high-income countries have shown over the same time period, the average high-income country. And the difference between those 2 projections, not the best high-income country, not even the U.S., which on some metrics is not so bad, just the average high-income country. And the difference between those 2 projections is 12 million lives. Now, how have high-income countries achieved that in premature mortality from non-communicable diseases? Certainly prevention in some areas, mostly tobacco control. But a lot of it is better access to cheap diagnostic and chronic care, particularly around cardiovascular disease, cervical cancer, liver cancer, chronic kidney disease, which we'll hear more about today, and diabetes. And here is where I see the role for the private sector in engagement. Some of this will be country-led in prevention, but building these systems to deliver these cheap, diagnostic, preventative, clinical care in low and middle-income countries is going to involve the private sector as well. And doing that at scale and at the volume that it needs to happen is hopefully where all of you come in. Thank you.
Hello. First of all, thanks to IFC for inviting us here and let us give this talk. And thank you, Jean-Pierre, for your excellent and kind introduction. So, first of all, Colombia. Colombia is a country in South America. We have 48 million people. Of those people, 97% are insured in health. So the poor people, that's the subsidiary or subsidiado regimen, and the regimen for the workers, they can all go to private or public hospitals. So seeing that for Colombia, Colombia has a bundle mixed in non-communicable disease and also communicable diseases still. So allocating resources for a country like ours, it's very difficult. So when IFC send us the questions to answer here, like what to do in our countries, we started asking us, okay, what should we do? What can we do? So the first thing that comes to mind is, what do the government get more taxes and more revenues from the people? But the trend of the disease is stiffer than the taxes in. So we'll be in the middle or in a long way. It won't work. Second to that, there's a some governments have made simple restricting barriers as price contention on treatment, on price contention on treatments and on drugs, but as in Ecuador, as we are seeing now in Colombia, if you stop or if you put a barrier on the price of medication for cancer, there will be a shortage of some medication. Some alternative drugs, most costly, will come in. And after that, you will get a bigger gap between the poor and the rich, because the rich can pay out of pocket the medication and the poor people won't get treatment. Another answer some countries had made is waiting lists. In Colombia, waiting list, it won't work because we have something that's called tutela. The tutela is that the people has the right to get their treatment, their best treatment. So if they go to a judge, the judge will give them a tutela, and then they will jump the waiting list. So in our country, a waiting list won't work. Some countries has made priority setting. Like, this is more important, I will pay this or this or this. We have now in Colombia new laws that permits the people to get all the treatment they need to in terms of getting better or in terms of even healthier ways. We have some patients that had trouble with our system to another countries to get treatments, even if we have it in our countries. So that won't work also. Also in cancer, time is life. So for treatment in cancer, the only way of doing the correct things with scarce resources is the right treatment for the right person in the right time. That being said, first of all, prevention. In our country, there's a lot of lacking of prevention in the insurance part. We have two kinds of prevention. Public prevention, that's for all the people, and one-to-one prevention that's made or has to be made by the insurance companies. It's not getting done. We're not getting good results in prevention. Then early detection, but real early detection. The soup is not always free. If we go like some cities has done, we're going to break the record of mammographies, but nothing happens with the mammographies. How can the people go and get treatment if they don't have money to get transportation, if they have to work that day, if they have to eat and they can have lunch for their kids are not in school. So people just will get a mammography and the results will be back in some paperwork, something like that. It doesn't work like that. So real early detection. And then right now our market that is working, we have fee-for-service payment. The fee-for-service payment, the insurance looks for the cheaper hospital in each of the treatments of one disease. So a patient can be sent to radiotherapy to one part of the city, chemotherapy to another part, surgery in another part, and that's a fracture that will take time, that you cannot promise quality. So the government has to have incentives for bundled payment or quality payment. In that matter, we have to follow guides. The guides has to be measured. We have to have outcomes. That outcomes have to be measured, and we have to get paid by outcomes. The only way of getting people better with scarce resources, it's to do the right thing. Good treatment, help people in other ways. Patients, cancer patients, chronic disease patients are not only patients, are people. They work, they have to travel, they have to eat. So we have to have ways to help these people get the best treatment in the right time and in the right place. Thank you.
Well, good morning, and thank you to IFC and Jean-Pierre. We'll keep this a little more interactive now. I'm a kidney disease dialysis transplant doctor first, an epidemiology researcher number 2, and then number 3, CEO. So that's how I rank my skills. The question is, 1 out of every 10 people in the US have chronic kidney disease. This is a fact that's not known. And worldwide, that's probably true. The question is the reason. There's more diabetes, there's more hypertension, and this is not funny. Most people are living long enough to develop chronic kidney disease. I usually tell my students a joke that in high school there was John and Jane, high school sweethearts, and at the end of graduation, John said to Jane, you should marry me or I'll die. And Jane, like any smart woman, said no, and John died 70 years later. So this is a term called competing mortality. For many diseases, you got to live long enough to get to a particular endpoint. Now, as I said, this is going to be a little interactive. I've got just 3 slides, so don't worry about that. This is the prevalence of people who are on renal replacement therapy. That means either dialysis or transplantation. And as you see out here, that in the industrially developed countries, that's North America and Western Europe, it's about 1,000 to 2,000 per million population. And then it drops all the way down to less than 50 per million population in sub-Saharan Africa. The highest is in Japan, more than 2,000 per million population. Any answers as to why it's highest in Japan? They live longer. Eating sushi is partially correct, but the reality is there's no kidney transplant in Japan. So there is no exit other than death from chronic dialysis. And that's the reason why it's highest in Japan. It's a Shinto religion. You don't donate your organs. You go to heaven with all your organs intact. The next point is, most of us need to look at the availability of kidney replacement therapy in terms of the economic consequences. Now, in the developed world, you'll see here that in the developed world, up here, that's where most of the dialysis is. But if you see here, this is largely an issue of the affluent countries. Now, there is a bit of a misconception that dialysis is completely dependent on the economic resources of a country. And most times people say, well, maybe, we can't afford dialysis. Now, Dr. Sangeeta Reddy is here, and Apollo Hospitals have pioneered dialysis in India. There's the CEO of India's largest dialysis chain, Vikram, here, who's in the audience. I'll tell you an anecdote. I moved to the US about 25 years ago, but I come from a small town called Mangalore in southern India, which has a population of 1 million people. 15 years ago, there was no dialysis. Quite an affluent town. And so what we did as a family was we created a foundation, and we collected used dialysis machines, and we shipped them to hospitals. And it's amazing. Those used machines, in about a year or 2, broke down. But the hospitals now realized that there was a demand for dialysis. They went and purchased dialysis units. Right now, 15 years later, in Mangalore, there are approximately 200 dialysis machines in 8 hospitals, and there are tens of thousands of people getting dialysis. So oftentimes, it just needs the tipping point to start a therapy, and then suddenly you realize you can afford the therapy. And soon, economies of scale bring the price down, and all of a sudden, what was thus far an unaffordable treatment becomes affordable to the masses. Today, there are 2.6 million people on kidney replacement therapy globally, and most of that is in North America and Western Europe. But the whole world is going to change in the next 15 years. As this slide shows you, by the end of 2030, there'll be 5.4 million people on kidney replacement therapy, and the graph below will show you that almost all of that growth will be in Asia and in Africa. And the picture there that I've shown you of an Indian patient getting dialysis is on purpose. In the past, you'd be showing a white Caucasian person on dialysis because that's what dialysis was. This is the face of dialysis tomorrow and 15 years from now. The last point I want to make is we've been talking about chronic kidney disease and chronic dialysis, people whose kidneys have failed permanently. What we don't realize is there are 13 million people each year who develop acute kidney failure. That is from diarrheal diseases in the developing world or from surgeries and coronary incidences or sepsis in the developed world. In sub-Saharan Africa, even today, little kids die from the want of one dialysis treatment. Malaria, kidney failure, all you need is one dialysis to temporize 3 or 4 days of life, and the kid lives happily ever after. Kids are dying because there is no dialysis. This is not a chronic investment. This is a one-time investment for a life full of productivity. It's not available today in many parts of the world. And that is probably one of the most important and urgent issues that we as a community need to tackle. Thank you.
So first of all, it's a pleasure to be here and to be among this exchange of ideas, information, and experiences. And so Mongolia also is a developing country, emerging market, so we have similar problems there. High prevalence, still some of infectious diseases, and fast-growing increase of non-communicable diseases, and also the fact that its increase is higher among younger, early age. So non-communicable disease compared to communicable, I think it's more national public good. I think it's very important that governments and have high commitment to tackling this disease. And of course, prevention is the most long-term effective intervention, and especially prevention among younger people. I think there is some data showing that $1 invested in a healthier kid increases 20 times productivity in the society. That's why interventions, and especially cultivating healthier lifestyle and preventing cultures, behavior of children from school age till the adolescent is the vital, I think, time period to invest. On the other hand, also control of the risk factors is also one of the important, I think, most cost-efficient interventions to address non-communicable disease. So basically, hearing about all the experiences from yesterday and today, and also based on our experiences, there is abundance of different best practices, interventions proven to be efficient to prevent and address non-communicable disease. The problem with emerging markets is that lack of political will or lack of focus on NCDs, and this causing that these spectrum of global achievements are not being utilized fully, exploited fully. So that's why I think there is huge room potentially to improve prevention and decrease prevalence of NCDs in developing countries, just learning what has already been implemented successfully around the world. And I think to this end, governments and professional organizations, there needs to be targeted team approach going around the world, learning the best practices and trying to cultivate in our own environment. And of course, as we are all aware that for preventive activities, there's not much credits. So that's why I think it's very, very important, good and better communication of how much savings these all activities are bringing to the society. And I really also believe that I think the notion that health is wealth is actually, it's coming to a tipping point of recognition. And the fact that in Davos, it's now extensively talking about health security, and about NCDs. I think it's also a momentum for us, for health professionals, to be more proactive in combating these issues. And of course, besides using what exists today, innovation in creativity is very important, especially, I think, in the area of health prevention and health education. So basically, cultivating healthy lifestyle is a part of daily life. It's very important. And I think lots of health education and health preventive activities, they need to be developed as a more entertaining, interactive, and less boring. And I think to this, private sector can play an important role. Just an example of disruptive thinking, I'm just thinking that, for instance, now these tall buildings, we have all elevators, and we, in many buildings, see the stairs like fire exits in the corner. I think, for instance, why don't we have like this building, first 3 floors, people have to walk stairs, and then elevator goes up. And I think these stairs need to be more reachable, more comfortable, and this is very important. Otherwise, obesity and all this in these days, all our lifestyle, it's causing these diseases. So that's why I think in urban development and planning, because it's public health, it's multi-stakeholder, multi-industry involvement is required. So, for instance, in urban development plan, why architects don't get, good knowledge of health utility and healthy lifestyle needs, so that it's incorporated already in the planning and development stage, for instance, within the construction industry. And also, as a private hospital in Mongolia, for private providers, so how we can support our countries to tackle disease, so we can provide very good treatment. Of course, treatment of already diseased people, it's a short-term intervention. And also, I think one important area where private health providers can play an important role is health screening. And health screening at affordable price, I think it's really also an area where private providers provide good intervention. And I was happy to hear yesterday that, for instance, this insurance companies providing this vitality program, encouraging healthy lifestyle, and etc. And in terms of also school education, there is so much can be done. And I think from private provider perspective, it's very important that that our products, we have tangible evidence-based results that can be comprehended to our colleagues at the national level, ministries of health and all this. And I think after all this public and private, split, and people saying that this barrier, I think it's rather more networking and more communication, and also I think engaging more government officials or professionals in what you're doing in the private sector. And then with understanding, with the comprehension, I think usually good results, it's convincing, and success breeds success. So actually quite optimistic, although we all experience in our countries a shortage of budget, but I think with greater focus in the international arena on these issues, and national governments for getting more donor support and etc. Probably preconditioning also certain NCD prevention-related measures will be very useful to promote this issue.
Thank you very much. With what you have said, I have tons of questions, but I'm going to open it to you first. So please feel free to ask any of us questions. Sir.
My question is fairly simple. Why am I not sitting there?
You can sit there. There's a free chair.
I tell you why I asked this question. Because nobody has spoken about I think the fourth leading cause of disability, which is mental, neurological, and substance use disorders. I am a psychiatrist, and I believe that until we address these conditions, which have a direct impact on cardiac disease, on renal disease, on diabetes, on diarrheal conditions in children, on low birth weight of children, I think we have not completely understood this subject. The second point, which is important, is that we are seeing a very steady growth in obesity. People with schizophrenia are predisposed to obesity. People with depression eat too much. Depressed people have very bad lifestyle. They smoke too much, and eventually they commit suicide. And the fourth thing I wanted to say, which is the last one I'm going to say, is that ignoring mental and neurological and substance use disorders is expensive. Go to any primary healthcare facility in private sector, in public sector, up to 25%, at least in Africa, and I suspect in the rest of the world, have primarily behavioral disorders. It's only that we don't recognize them. I could go on, but will not. But I think a little bit of focus on the true cause of obesity and smoking and poor lifestyle choices is important for us to look at. Thank you. I don't need to come and sit there.
Thank you. I think what you mentioned is quite important and is a byproduct of a modern society. And I think we all feel it in our jobs to a certain degree. And for some of us, it's harder to cope with pressure than others. And sometimes there's not that lifeline for a lot of people, that helping hand, that person that you can basically tell and lean on to make you through the rough patch. But I would like to basically pass it to our panel.
Sure. Let me make sure this is on.
Yes.
What you'll be pleased to know is the report we did actually did cover mental health as well. That's not an answer to this panel per se, but it is a area of focus. As you rightly mentioned, mental health is associated with, poor mental health rather, is associated with people having multiple NCDs. Multiple NCDs tend to be the largest driver of healthcare costs. And it's a real concern from that perspective. One of our recommendations from the report does focus on integrating better mental health into primary care. I think one of the challenges, though, of people talking about mental health in the conversation around NCDs globally is twofold. The first is the data in low and middle income countries is still extremely poor. And unlike other areas where we have much better data, when you look at the data that has emerged while rising on disability, we still have a sense that the quality of the data, particularly emerging from low and middle income countries, is relatively poor. And the second is, unlike a lot of other areas where you've started to make progress on premature morbidity and mortality, in high-income settings, you haven't really as much on mental health, and it remains a problem worldwide. And that has, I think, been a challenge too. But it is a topic we covered, and it's a significant priority, as you mentioned.
Oh, I was wondering probably if Brian, Bolorma, or Alejandro, you can just briefly answer the gentleman's question from your point of view. Whenever you see people in terminal kidney disease, whenever you see people in Mongolia that have some incurable disease, whenever you see people with cancer, what is that aspect? How do you deal with it?
Not only when they have the last stages of the illness, but also smoking. We have addressed one question. When you go to a doctor, that doctor in cancer treatment asks you, do you smoke? Yes or no? And that's all. He won't ask you about it, why, what's happening, what to do with it. That's not only in Latin America, but also in the United States and some developed countries. So we have to have resources in terms to lead the patients to treatment, in smoking, in mental health also. We have some psychology in our institution, but it's only for the patients, because when you know you have a cancer, for sure there's a mental storm going on your head. So it's a big issue in the healthcare system. We treat diseases. We don't think in health terms. And that's the big question.
Brian, Bolorma?
So, for instance, in Mongolia, we have a national mental health disease prevention and program, public health program. And basically, most of the activities are directed towards community-based services. So basically, mental health services incorporated in primary health care and trying to provide support to these people so they are within community, not being isolated. Of course, as any public health programs, shortage of funding is a big issue. And also the training of health professionals is another issue, especially because of internal migration. Turnover of trained staff is a big issue. You invest 10 person to handle this type of patients and support, but they're moving a lot, and so its capacity building process is always so one of the issues that continuously being, up to our attention.
Mm-hmm. Brian?
I'm glad you brought this up. Thank you. The key here, I think what you emphasized was that as we talk about non-communicable diseases and chronic diseases, and as all of us are growing older and living longer, mental health is just increasing in incidence. The problem is stigma. At a cocktail party, you're quite happy to tell someone, I'm diabetic, I take insulin, but how often do you tell people, hey, listen, I've got schizophrenia or I've got depression and I'm on medications? It's a social stigma, and as long as awareness and the social stigma doesn't get lifted, it's a big barrier to advancement. That's number one. The second issue is that if you go to the US, there is a walk for cancer, there's a walk for kidney disease, there's a fundraiser for Alzheimer's. Not often do you see a fundraiser or a social organization which is raising money for depression. There are, but not in the same league. And finally, in broad swaths of the developing world, there are no mental health professionals. They're just absent. So these are issues that we have to take on. Unfortunately, it has fallen to be low on the priority list of governments and social organizations. Do I have a solution? I live in the world of pharmaceuticals. One of the challenges has been that there haven't been dramatic improvements in pharmaceutical therapy. When those dramatic improvements occur, then there are organizations with a commercial vested interest to develop awareness, adoption, because it's in their economic interest as well. Unfortunately, the advances that we've seen in cancer, cardiovascular disease, and so on have not occurred in the same dramatic way in mental health.
Thank you. I think, we already have a line. Gentlemen.
Great. Thank you. Andres Gutierrez from Mexico, a company called Medica Santa Carmen. We have kidney dialysis and diagnostic centers. And by the way, we employ a psychologist rather. She does narrative therapy, and we don't do it because it's mandated or required. We do it because it's patient wellness, and we've had a dramatic impact on patient adherence and follow-through. Two questions, really. Dr. Belorma talked about the public will of recognizing NCDs and doing something about it, and certainly not only in Mexico, the government is recognizing that that's an issue. There's also a lot of NGOs. My question is, what do you think that us as private sector could do to really promote prevention? And then the second question for you, Dr. Pereira, is you talked about age being correlated with NCDs. We see a lot of high incidence with children. Our median age is 46 years old and of patients in dialysis. And so children as far as NCDs, and then what can we as privates do to collaborate with NGOs and government?
You first.
Okay. So in terms of private sector involving in the prevention, I think there is actually quite a big playing ground in terms of the conducting health screening programs. And also, I think early detection of NCDs and NCD-related risk factors, it's really meaningful interventions. And what's happening, for instance, in our hospital, we are a tertiary hospital. So besides our tertiary services, we have our health promotion department. So where we have government, non-government, international, and corporates having annual health checkups within our hospital. And we're really aiming to provide very affordable prices for these checkups. And as a professional, what we're seeing that really with high prevalence of disease, we see that we're actually making a lot of early diagnostics of cancer, detecting the high blood pressure and high blood sugar and all this among people between 35 and 40 years old. And I think having these timely diagnostics and helping these people to put in lifestyle change regime and the recommendations and providing follow-up services and personalized health lifestyle programs, also healthy dieting, and these kind of things also, I think, being very meaningful interventions. And also, as a part of our Social Responsibility Act, we're also covering with health screening remote vulnerable group area children, kindergartens and schools, so that we're looking after like oral health and ENT services. And it's, of course, to compare to big numbers, these are small, but anyhow, we really believe that these small things are really helping to these individual disadvantaged people to take right path to have more healthy, good health, and better learning, schooling, and more successful, lives.
Brian?
So the point that you raised is not true just in Mexico, but in big swaths of the US and all of Latin America. Hispanics are at high risk of diabetes, and on top of that, the current lifestyle has led to rampant obesity. In fact, there are children who are in their teenage years or even less than 10 years who are developing type 2 diabetes, which was never known in the past. The good news about kidney disease is that the screening costs less than $1. Anybody who has family history of kidney disease, is obese, has diabetes or hypertension, you do blood pressure, a simple dipstick for albumin in the urine, and a simple serum test for serum creatinine. Costs less than $1 to do this screening. And kidney disease, although is not preventable, you can slow the progression of kidney disease that would end in dialysis. And those drugs are cheap. So screening is inexpensive. Screening should be done. But at the end of the day, you've got to go back and prevent the diseases that are causing kidney disease. Most importantly, diabetes, and as a feeder to diabetes, rampant obesity in many parts of North and Central America.
Probably. The gentleman has another question.
Yes, good morning, everyone, and thank you for a great panel. Trevor Gunn here from Medtronic, a large medical technology company. So I had a comment, a question, a comment, and a question. This will be very quick. To our colleague here, I completely agree with you. I would urge, and specifically with Tom's remarks, for you to take a look at the political declaration of 2011 by the United Nations. It not only called out 4 major disease states, but it also called out mental illness. And I absolutely suggest we're one of the 10 companies on the inside of that meeting that we hold political leaders responsible for those beyond the 4 major categories, and mental illness being one of them. A completely separate question, it's actually a question for any one of the panelists that would like to answer this question. Do you consider healthcare as a part of infrastructure?
Yes.
Yes.
Yes?
Yes.
No?
Yes, yes.
The panelists? Yes? Okay. So the comment is, you may or may not be surprised to know that if you look at multilateral development banks, the unilateral donors in the world, infrastructure almost never is considered as a part of the health. Healthcare is rather not a part of the infrastructure investments. It's seen in sort of in the social sector. You have a big debate raging in the world right now, major capital flows going towards dams, roads, power generation facilities, traditional definitions of infrastructure, yet the contrast is when we at least speak to health ministers or heads of state, they all consider healthcare to be a part of infrastructure. So my final question, what do we do if you agree with the premise that this should be, that our sector should be much more a part of the major capital flows going into this? What would be your suggestions as to how to make it that? We're left out. We're not even the caboose on the train in this discussion. We're running behind the train.
Would anybody like to take that interesting question?
Take all the questions perhaps,
Or probably I have more of to the gentleman. In terms of infrastructure, if I look at my previous life, and I was in New York, I was an investment banker in New York, and now I look at the trends that you see in disease, the need for the private sector to be involved in the solutions, just purely from a demand and supply standpoint, a lot of people are realizing that not only are there opportunities to make money, but also to help people, particularly in emerging markets, where most of the growth is going to be for the next 10 to 30 years. From a practical standpoint, we're already seeing that. A lot of our clients, our potential partners, are coming to us and wanting to expand in emerging markets. Because, and this was one of my questions for the panel, the governments are extremely stretched in emerging markets, but you're going to have a social pressure to deliver care. So that is going to have to be met somehow by the private sector. And the point for the private sector is to determine the right price point at which to deliver the services. So I think if you look at it from a demand-supply standpoint, it will come because the opportunities are there, and more companies are focusing in emerging markets and are finding some formulas where it makes it profitable for them to be involved. So I don't think it's going to be immediate, and I think you have a point, but I think we're moving in the right direction and quite fast as the social needs are increasing dramatically. So I don't know if you have.
Yeah, the only thing I would say is clearly the private sector has a role in extending preventative diagnostic and chronic care at a lower cost at a higher volume. That's no question, and I think the panel has talked about that. But I think in other areas of global health, the private sector has played an important role as employers, raising the priority of addressing these issues. It certainly played a large role in the HIV crisis by increasing, as Jean-Pierre mentioned, the demand for investment in this area. But I think one of the other areas where it can make a big difference is workforce wellness programs, whether that's by insurers or companies themselves, and that's really where you're seeing a tremendous amount of innovation. I agree with Trevor. I think there's a lot of work to be done. I'm less concerned about whether healthcare is defined as infrastructure and not, and more concerned about whether it's seen as an economic priority. And I think we need to do more work in building the case and the interest in that, particularly with chronic disease, where I think it's most clear that this should be an economic priority.
Any other questions?
Yeah, I think thank you. Mine is more of a comment in that I think my name is Bernard Olay. I'm from Nairobi, Kenya. I work with the World Bank. But the main challenge that we see, particularly in sub-Saharan Africa, in response to NCDs will be in the space of human resource. The equipment, you can deliver the latest dialysis machine to Africa the same way iPhone 6 reached Nairobi, so it will not be a big problem. But to train people that can offer this care in Africa is going to be one area of one major challenge for us to respond appropriately. And right now, most of the countries don't have any training programs, and the ones that are trying to train people are trying to train a US, UK type of nephrologists using the same curriculum, and they're just not producing the right numbers and quickly enough to be able to respond to the rising need. So how the donors and the government and the private sector talk and solve this problem will determine whether we succeed or not. Thank you.
Can I just make a comment to that?
Yes, please.
That's a great point you've made. In fact, in Africa, the models that are evolving are quite elegant. They're not sending people to Europe or to North America for training. They're sending them to India for training. And they're getting nurses, technicians, and doctors from India to come to sub-Saharan Africa, pay them to work there for a while, train the local people, and go back. So great models are evolving. So I'm just keeping it brief. I'd be happy to chat with you offline.
Yeah, and also I think we need to take advantage of e-learning. I think it's very cost-effective and it's very realistic these days.
Yeah, the one, if you don't mind,
please.
just to quickly add to that. I think this is a very important point in an area where donor and international investment has helped in other areas of health in terms of being able to provide critical health services with lower skilled workforces and building the training programs from that, whether that's through community health workers or patient peer learning networks. And you're starting to see some investment for that, but the real challenge, of course, on non-communicable diseases is donor investment remains incredibly low. Currently, NCDs represent 1% of global health aid. In the United States, they represent less than a tenth of what the United States provides, a tenth of 1% of what the United States provides globally in health aid. And I think that's a critical role for that to increase.
Also, in our country, it's very useful, and we're not using it right now, networks between the big hospitals and the primary cares, and also telemedicine. For us, it will be very useful because we have the universities, we prepare doctors, but all doctors want to be in the big cities and in the big hospitals. So when you measure how many doctors per person you have in our country, in the big cities, they are kind of okay. But if you go out to the towns or to the farther cities, there are no doctors, no nurses. So something will have to be, and we don't have incentives to pay them good enough to go outside of the big cities. So networking and also telemedicine will have to go in.
I mean, for the gentleman, I fully agree, and I think Ian is back, and it's one of the conversations that we had with him, particularly in Africa, for companies that want to set up business in Africa. One of the key challenges is to finding qualified personnel in terms of doctor, nurses, and that impedes a lot of companies that want to do investments in Africa. One of the things in Colombia that through our conversations with Ian we were impressed is that the government is also incentivizing to train much more doctors, many more doctors. And that's also what made a crucial difference in the quality of care that you are delivering in Colombia. So if we could see that openness for opening medical schools or regional medical schools in the areas, that would help a lot with the deficiency of medical doctors. Please. And I think the last question, and then I will close it, and we will let you go.
Sorry.
Oh, sorry. Sorry.
Okay. Shall we just
Yes,
both
please.
do it so that we can. Okay. So I actually had a question for Tom. Next week is the World Health Assembly, so I'm very cognizant of this as I go. Ebola happened, and now there is a global discussion that this is the global health security challenge. But when I listen to you, Tom, it's NCDs is where we should be focusing. So the question is, you're in Washington, what are you doing about this? Because I'm personally very worried, because if you look at the statistics, Ebola cost 4.8 billion or something like that, and prevention would have been 1/3 less. But now we forget about NCDs. So that's my first question. And then to the panel, we were pretty successful during the MDGs with Gavi, Global Fund. Why don't we have similar public-private partnerships for NCDs? And why don't we have these partnerships to address health system strengthening, like health workers, infrastructure? So is this something that we should be thinking about for the future? Next week, interestingly, the World Health Organization has called for-profit agencies to meet with them to discuss how we can participate in universal health coverage. I represent Merck, a German pharmaceutical company. This is completely new for me. So it'll be interesting. So it seems some things are changing, and do we have an opportunity to push the NCD agenda ahead? Thank you very much.
Thank you.
Can I?
Would you?
Yeah.
Yes.
Hello, I'm Gisela Hab, I'm from GE Healthcare. So I have a comment and a question all rolled into one. So I think that as a solution, we need a whole system approach to really move this forward. Hearing what people have said from the questions, it's really important that when you're looking at, how you improve healthcare systems, you look at the leading causes of death, the leading causes of disability, what costs the most, the number of people who present and the conditions they present, because when you have that integrated approach, you would look at mental health, you would look at communicable diseases, you'd look at everything, and then how then you manage the budgets to develop an infrastructure that can prevent what can be prevented, diagnose earlier what needs to be diagnosed and treat. Till we start working as integrated healthcare system and not being silos, because all companies focus on what we think is most important, we are never going to improve the healthcare system. So that's my comment. So I throw it to IFC and the panel that how can we start solving this by working together as one integrated healthcare system? Thank you.
Thank you. Would you like to take the first question?
Sure. I agree with the speaker on the priority of NCDs. I don't think people have forgotten about NCDs. I think, sadly, people haven't started to really think about it from an international perspective. I do not view Ebola as a episode about Ebola per se. It's about a failure of health systems. And obviously an increase of risk that comes in part through urbanization and increased regional travel, and it will not be the last pandemic, sadly, we see in that setting. I also think a lot of the same factors are driving the NCD challenge, particularly on the failure of health systems in terms of what we're doing. I mean, beyond the report, I testified last month before the Senate on NCDs. I spoke at the World Health Organization, organized a consultation with Margaret Chan on NCDs. I spoke at that as well. We are briefed virtually every executive agency with this. I've spoken to 40 different congressional offices on it. We are pushing the issue forward. I think the challenge you have is everyone we speak to says, we're still learning about this problem. We don't hear about this from the health agencies and development agencies that this is the issue. And I think to tie to the broader comment on the end about integrated health, in global health, we need to move less from a supply-driven model to a demand-driven model. Instead of addressing the diseases with the interventions we want to provide, we need to respond to the needs of the people we are trying to work with, and that's true on the private sector as well.
I think as private, we have to pursue quality, and that quality is the measure of outcomes. And when you measure outcomes and guidelines, you will measure the whole patient way into the hospital. So you will be getting if I get all the patients in late stages, my outcomes will be very bad as a private hospital. So I need to work in a network with the insurance company, with the government, with the primary care providers, so patients will come in faster, better diagnosed, with quality diagnosis, in better shape nutritionally. They can go in the hospital. So looking the patients as a whole, working in quality, we will get better results, and we will have better resources to work with.
So I think about epidemics, I think it's a global public health good. That's why I think for this global central body to coordinate, also to mobilize more resources, and it's much more different approach. It's a global agenda. When you look at the NCDs, the consequences are actually at the national level. It affects the productivity of the nation. So that is why it's, I think, very important that public health, actually, this issue becomes a political issue, and it's very important that there is strong leadership to convince government that the investing in prevention is actually, it's good investment which yields quite good returns. And this, we need a lot of evidence and data to back up on this side. And also, I think we need to improve efficiency of our operational, because, I mean, there is number around 20 to 40% of waste we have within the health spending. So that's why I'm in all hospitals and institutions, they need to improve efficient use of existing limited resources.
Mm-hmm. Brian, would you like to add something?
Just two comments. One is, while we are focusing on NCDs, the reality is that the flu pandemic of 1918 killed 100 million people. And that has no territorial, political, or geographic boundaries. Ebola was a warning sign for us. But Ebola, in the big picture of things, the good news is it's not transmissible by aerosols. So it's contact. That's why we could control it. You're not going to be as lucky with flu. And the reality is that that's one place where global organizations will have to step in, because each country will stockpile for itself when a major transmissible pandemic occurs. So to me, that's what keeps me awake at night. I'm biased because my company, Vistera, we have engineered the first global flu therapeutic, a monoclonal antibody, so I'm biased. I'm declaring my conflict of interest first.
An honest man, so rare today. Probably let me summarize the key points of each of our speakers, because I think they are each of them has a very different perspective that is very, very interesting, starting on the order of their interventions. Tom shared with us that NCDs are no longer a rich country a problem. Higher than $3 trillion in lost income, but also I would add is not only the lost income, but also the lost skills. And in a lot of emerging market countries, because people die younger, it is not possible for these people to transmit the skills to younger generations. And there's a permanent loss of skills. What is driving the crisis? Even though we have lower infant and child mortality rates, there's no improvement in the healthcare systems across the world. Spending on healthcare is still low. And he gave the example that government spending in Africa is equal, in aggregate, is equal to the spending in Poland. The health system, and I would say also the donor community, is focused on communicable disease and not non-communicable disease. He ended up by saying that prevention and better access to diagnostics and care are the key to finding non-communicable diseases. Alejandro, from his
cancer, let's say, practitioner's view, shared with us that the government in his country and also in other countries have tried many things, from increasing the taxes, price contentions, which resulted in shortage of medicines and worse health outcomes. They also try waiting lists, priority diseases. And for him, cancer, you have to take into account the timeliness of cancer, treated readily for the better outcomes. Prevention, again, early detection that needs to be followed by a quality treatment. Brian gave us some very interesting statistics. 1 in 10 people in the US have kidney disease. I did not know that. The reason, diabetes, more hypertension. People are also living longer lives. And I read in a paper that I shared with Jon that was quite terrible in its conclusions, but I think it's quite true. Because of the advances in medicine, because of the advances in pharmacology, most of us are going to live longer lives. But now we're fighting chronic disease. We're learning to live with chronic disease, but now we're going to die by even more horrid diseases that are neurological diseases that we barely do not know how to treat them. So that is not the uplifting part. Brian also gave us the statistics. 2.6 million in the US and Europe are basically having kidney disease, but that number is going to increase to 5.4 million, most of which is going to be in Asia and Africa. Urgent issue. We need to invest today. It is not a lot of investment. He gave us the example of the donations of use dialysis disease that triggered the response and then triggered the ability of people to demand for better care. And I think what I remember more is your example about the incidence in kidney disease in young people. And what you mentioned, that 1 or 2 treatments could basically save the life of young kids and them having a productive life. And that, I think, is very, very important. Lastly, but not least, Bolorna, again, mentioned prevention and screening as a critical tool in fighting non-communicable diseases. She also hinted at the lack of public and political will and focus to treat NCDs, and also the shortages of budgets. And that's a recurrent problem in most emerging markets today. She also pointed out that the savings of fighting NCDs for our societies, we need to recognize that to have productive societies and not to hinder the economic income of particular countries. One of the interesting examples that you gave was the stairs, and that architects should be much more inclined or think about people's health and the pursuit of exercise, not just mental exercise that is driving most of our daily lives. And again, I think prevention and screening. So if I had one last slide to put up, and I do not know. You're putting up the last slide? Yes. What we learned today, we need to have better awareness of non-communicable diseases. We need to have a focus on non-communicable diseases. We need to have the donor community, also the one previous to that. We need to have the donor community also shift into non-communicable diseases, not only communicable diseases, particularly in continents that are suffering from NCDs as Africa. Prevention, screening, timely and quality treatments are going to be the key for the future. And in that, the private sector has a crucial role to play in this. And to close, this is my last slide, and it gives you the extent of the change that we need. Most of the population is in emerging markets. However, healthcare expenditure, most of it is in developed markets. We need to basically push a lot of that spending and increase that spending into emerging markets.
With that, I wish to thank our distinguished panel for taking the time to travel from very, very far away and also sharing your insights, and to the audience also for coming here and listening to us. Thank you very much.